hopefully this is recording now. So if you guys have any questions to begin with any of the material you guys have hopefully looked at maybe a little bit. Not at all. Okay. Well, at least you're honest. That's okay. All right, we're gonna do another Kahoot and we'll at least talk about the question. So let's do. Let's use. Okay, please do not have any inappropriate names once again, because this will be on the internet in perpetuity for eternity. You don't want to be, yeah, any bad names. All right, here we go. Trap queen. Okay. I feel like that's inappropriate, but I don't know why. Special K, I like that one. That was good. No. That's obvious. What is it? Yes. Turk from Scrubs, like Turkleton? That's a good one. Do I have 5 more people logging on? You need a JD to go with Turk. 3 more. Anyone else logging in? Okay, got 1 more. 2 more. Are we missing 2 people from class today by any chance? 1 more, okay. If you're having technical difficulties, that's okay. You can. Anyone still waiting? I'm gonna go ahead and. We had 60 now. We're down to 59 people are leaving now. Like what's? That's not very nice. Dude, this is not good. Can you join in like mid-game? I don't actually know. Yeah. Okay. Well, we're gonna get it started. We'll try 60. That's pretty good. Okay. 22 questions. We'll talk about stuff as we go along and see how that goes. Okay. Which of the following signs and symptoms is consistent with cholinergic poisoning? Constipation, mydriasis, bradycardia, urinary retention. I'm sorry if I misspelled anything. I don't have good spell check in my Google Chrome. What do we think? Cholinergic poisoning, right? You guys remember the mnemonic for that? The dumbbells. Hopefully it's encouraging good discussion. Hopefully not too much side talk. Bradycardia was the correct answer. Does everyone know why that's the correct answer? Huh? The killer bees, absolutely right. So bradycardia, bronchuria, bronchospasm, those are the big things that we worry about. No one's going to pee themselves to death. No one's going to cry themselves to death, even though you may feel like it on the inside. Right, so bradycardia would be the good one. So all these other things would be the opposite. And again, you'd see things like constipation, urinary retention, mydriasis, and what type of poisoning? Obviously, yes, anticholinergic. There you go. So it would just be the opposite there. Fantastic. That's a good one. Do you guys remember what the... Not sure who that is. Just stop the... Nope, this is sticking around. All right, we're going to keep going. Which of the following signs would be consistent with sympathomimetic poisoning? What are some examples of sympathomimetic drugs? Adderall. Yep, Adderall would be a good one. Crack cocaine, right? That's another good one. Cocaine's a heck of a drug, as I say. Well, PCP, absolutely, I would fall in that category. Well, angel dust. So think about it, you got too much catecholamines, norepinephrine, epinephrine just flowing. What are we going to see? Whichever answers it'll record. See my drysis. Good, absolutely. So typically not constipation, not usually, because again, if you think about your whole system just being kind of on overdrive, you may see some diarrhea, certainly maybe some overactive bowel sounds with some pathomimetic type ingestions, but that's not constipation. Not usually urinary retention either. It usually is going to be kind of normal to, not really any changes you're going to see from that standpoint, right? But certainly my drysis. So if you have someone who comes into your ER and they have a big giant pupils, you should be thinking, some sort of ingestion sort of thing, right? So either anticholinergics, which can cause that, or certainly some pathomimetics are common ones. Yeah, antihistamines certainly do that. One of the things you'll see is that typically with some pathomimetics, like cocaine or amphetamines, they're a little bit more responsive to light than you'll see with the anticholinergic. So you can usually see some constriction showing lights in there. Yep, good. Any questions on that? All right, fantastic. See who's in the lead. Poppy's coming back. Looking pretty close. All right. Naloxone is to morphine as blank is to diazepam. Easy, huh?
Easy.
Fantastic. That's what I like to see. People are very sure about this answer.
We love analogy.
Huh? Okay. That's okay. Fantastic. You guys made the brand name for flumazenil.
The best.
Anyone know the brand name for that?
Romazicon.
Yeah, Romazicon would be the brand name, right? So this would be our benzodiazepine receptor antagonist, right? So what else does flumazenil work for? That's right, nothing, right? So flumazenil only works for benzodiazepine, similar to how naloxone really only works for opioids. Sometimes you can use naloxone for clonidine ingestion. We've used that occasionally. Yeah, what would you use physostigmine for? Anticholinergic, right? Because physostigmine is a reversible acetylcholinesterase inhibitor, so it helps to increase levels of acetylcholine. So if I had like a Jimson weed ingestion, or if I had like a diphenhydramine or something like that, I could reverse those anticholinergic effects by giving physostigmine. It helped to, outdo that competitive antagonism you see there. What can I give atropine for? That would be good for the muscarinic signs of an cholinergic poisoning, right? So if they're having the dumbbells, it can help to reverse that. And then what can I use ethanol as an antidote for? Ethylene glycol, methanol is another good one. Yeah, so that's kind of old school. We don't really do that anymore, but nowadays we use another drug called flumetazil. That kind of does it's a synthetic inhibitor of alcohol dehydrogenase. But back in the day, we used to use IV alcohol drips in order to keep people drunk to prevent ethylene glycol from breaking down to its more toxic constituents. Okay, fantastic. Score's looking pretty good. Not seeing a whole lot of changes up here, so. All right, which of the following would identify a poisonous snake in Florida? Again, you remember why we don't measure snakes in feet? Because I got none. That will be on the recording. All right, so how can you tell if this snake is poisonous or not? It's hard to tell when you're running away, but...
Don't you mean venomous?
Venomous, yes. Can envenomate you. Yeah,
Did you study snakes?
Huh?
Didn't you study snakes?
I did study snakes, yes, of course. We use terms interchangeably. You know how it goes. Okay, so right. So a rounded head, not necessarily, right? Which kind of venomous snakes would you see a rounded head with, though?
Coral.
Yeah, just a coral snake. But typically, if you're looking for, a very venomous snake that's going to chase after you, it's usually the triangle-shaped head, right? Elliptical pupils. Some of them are a little aggressive. Pygmies tend to be a little bit more aggressive than others, but typically they're not looking at you like you're the next meal. Elliptical pupils would be the definite one to look for, right? So they have kind of the cat's eyes. That would be a good thing to note. Stripe banding pattern it's not really consistent amongst any of the snakes. Certainly, a diamond pattern may lead you to think more like a diamondback or something. And then it's not red on black coloring, but yeah, red on yellow banding pattern. Yep, fantastic. Red on yellow kill a fellow. Okay, which of the following would be indicated for a bite from the following snake? And it should show a picture. Here we go. So if this little guy came up and bit you, what would you do? What would you give? I guess what would not be indicated in this case? What would you not give this patient? You gotta make sure to read the question. I can't bold words, and I don't know how to do that. I'm not very good at Kahoot. I think I got a picture. Just flip the table.
Well, no, she didn't. She did that on the paper.
All right, what would I not give?
I know I saw those.
The problem, the guy's trying to be so quick on the buzzer there. There's 2 correct answers. Yay! Again, I'm not going to do that on the test, but right. So the things we would not need to give include the North American coral snake, because what kind of snake was that? It was a cottonmouth or a water moccasin, absolutely great. And so we obviously not give coral snake antivenom for that because there's no homology there between the venoms. We would potentially give crofab though, because that would be the antidote for that. Tetanus vaccine, should you give that? Yeah, you should always update them in case if they don't know when their last booster was or they've never been vaccinated, then certainly give them a tetanus update. And then, do we need to worry about rabies in snakes?
No.
No. Yeah, usually it's more mammalian critters.
Will there be pictures on the exam?
There are no pictures on the exam. Maybe questions about how to identify, but honestly I hadn't never thought about it because I've never put pictures on the exam before. Yeah. Team Viper. There you go. All right. Eileen pulling out in front. Okay. Inactivated vaccines cause which type of immunity? There's a lot less talk here. People are unsure. I'm going to cover this on PEDS, so you should have pretty good understanding. Stuff, right? Hopefully. I guess I should say don't Google answers while doing this. It kind of defeats the purpose for your fake internet points that you get. As a, huh? Gotta win the fake nothing. All right, what do we think? It's active immunity? Yes, that would be active immunity. Okay, so what would be like innate immunity?
When you get sick.
Yeah, like our skin's like in this, innate things that you just have that prevent you from getting diseases and whatnot. So that would not be the case. Booster, you can potentially use an inactivated vaccine to work as a booster, but it's not really like a booster immunity. It doesn't really make sense. That was kind of the red herring there. Passive immunity, what would be some examples of passive immunity? Maternal antibodies. What else could you do? Yeah, antivenom would be a good one. IVIG is the other big one that we give very frequently, right? So that would be passive because patients not producing any immunity on their own. We're just giving them something that makes them immune temporarily. But the active immunity, we're challenging the patient's immune system. They're generating their own antibodies now. Fantastic. All right. Continuing on. Which patient would produce the best response to an inactivated vaccine? 14-day-old infant with no medical problems, 6-year-old male under active treatment for leukemia, 16-year-old female, or a 26-year-old man with HIV/AIDS. Got the best response to an inactivated vaccine. Not too tricky, but a little tricky. All right, so what do I mean by best response? Right, so you're looking for someone with a competent immune system, because if you don't have a competent immune system, what does that mean for your response to the vaccines? You can't really mount a good response to it, so you're not going to be able to actually have immunity, right? So that's why you potentially have to give repeated doses, or they're just not really going to have, retain that good memory for that, right? So obviously the patient with HIV/AIDS, if they have AIDS and they already have, an AIDS-defining illness, that means their immune system's probably pretty crummy at that point, so unable to mount that response. Patient on active treatment for leukemia includes chemotherapy, so obviously that would be a patient who is immunosuppressed. And then how about the infant? Yeah, pretty immature immune system. Again, also think about the maternal antibodies maybe making those vaccines less effective, right? Because if the antibodies already neutralizing them, the patient's not really responding to that at all. So again, 16-year-old female would be the obvious response there, just because she has, assuming no other medical conditions, has a competent immune system. Okay. Moving on. So a patient receives an inactivated vaccine today. Which of the following are true? He misses his next appointment. He has to restart the series. He can only receive other inactivated vaccines today. He needs to wait at least 6 weeks before the next dose, or he can receive a live vaccine next week. Noticing a lot less chatter as we get into more unfamiliar territory. You guys should know this. Should. Huh? I have so much faith in you guys. To not purge and dump all that information you learn from one test to the next. You would never do that. Okay, so... Oh, a little bit of spread there. Okay, so if he misses his next appointment, he has to restart the series. So when would you have to restart the series from missing doses? It's been like months and months and months, right? So again, if he misses it by a few days, totally fine. You want to err on the side of giving it late rather than too early, right? Giving it too early means you're not going to have as good as that kind of memory response to it. He can only receive other inactivated vaccines today. Why is that false? Yeah, you can give live at the same time as inactivated. That's not going to be a problem, right? He has to wait at least 6 weeks before his next dose. Yeah, 4 weeks is the minimum time you have to wait between doses. But again, remember in those inactivated ones, you'll typically see like, say 6 months or a year between the last couple of doses in order to just get that really kind of good memory response there. And then he can receive live vaccines next week. That's totally fine. Any kind of time period between inactivated to live is fine. What's kind of the caveat with that though? Yeah. Yep, yeah, so live to live has to either be the same day or has to be a month apart. Yep, good. Fantastic. All right. Which sedative agent would be used for induction prior to surgery? Remember, I noticed that induction, sedation prior to surgery. Use it for induction of sedation. So I want to knock this patient out. How do I do that? We need like 1, 2 more people. Wild guesses are totally fine too. Propofol, all right. Let's talk about this one. What do we think? Oh, that's pretty good. So why do we think propofol is the correct answer?
The milk of amnesia.
It's the milk of amnesia. You give it IV. How fast are you out? Yeah, within seconds you're going to be out, right? You can try to fight it. It's not going to work, right? So propofol is good for induction of sedation. What about like desflurane and sevoflurane?
Those are anesthetic.
Yeah, those are inhaled anesthetics. What are those good for? Maintenance of sedation. Yeah, absolutely. So again, you start them with an induction agent. What else could I use for induction?
Ketamine.
Ketamine's a good one. Think about things like your barbiturates, like phenobarb, like fentanyl, things like that are also good induction agents. Etomidate could even potentially be used, but it's not usually used in the surgery setting so much. It's good. And so how about cisatracurium? What kind of drug is that?
paralytic.
That's a paralytic, right? So you don't want to give that to your patient who's got no sedation on board, right? That'd be bad. They'd be very upset with you when they wake up. Note with the propofol, you'll always know if a patient's received it if they come into the PACU or the post anesthesia care unit, if they have like a 1 silver glove on, right? You know they've been hit by a smooth criminal.
Too soon.
Oh, sorry. You know, we during my fellowship, we had a good relationship with the herpetologist. I tell you guys this story. We had a good relationship with the herpetologist, the snake guys, and so we take our rotators there every month, and it was nice because we actually got a kind of behind the scenes visit at the Jacksonville Zoo. So we got to go into like the snake pits and all that kind of good stuff. They'd pull like a big like timber rattlesnake out, but interestingly, we had one elephant that actually came from Neverland Ranch. It was, I don't know if it was a child elephant. It had been there for a while. But I would ask people, I was like, do you know how you can tell if it was Michael Jackson's elephant or not?
Oh no.
I said, it was the one walking backwards.
Sure,
Anyway. All right. BH is now out in the lead. Okay, let's see. Which opioid may cause chest wall rigidity when given too quickly? Is that Heron? That Morphine? What could it be? What's hydromorphine? What's the brand name for that one? The Dilly-Dad? Yeah, that one. Bad patients come ask for their Dilly-Dad. I'm allergic to everything else except for that Dilly-Dad. Okay, whatever you say. I hope my cynicism is never infectious to you guys. You guys have to develop that on your own. So fentanyl is the correct answer there. Wow, that's a pretty big spread there. Right, so fentanyl is a big one to remember for like surgery type settings where if you're using this as an induction agent, if you push it too fast, you can see that chest wall rigidity, and now they can't really oxygenate very well. Do you guys know how we would treat that? You may give Narcan to try to help reverse that, but then your patient's not really getting any kind of sedative effect from the fentanyl, which may or may not be okay in that setting. The other thing you can do is actually give a paralytic. So if you give something like a Rocuronium, a Vecuronium, you can actually help to paralyze those muscles, and then they'll be a little bit more compliant, and you can oxygenate them better, right? So again, fentanyl, chest wall rigidity, too quick. That's the big thing to remember with that one. Good. Morphine, hydromorphine, you don't really see that from, and hopefully we're not giving heroin to our patients in the hospital. Some alternative, maybe like an alley out back or something, but not in the hospital. Okay. Moving on. Which sedative agent can cause this side effect? And I forget which picture I put in. Oh, there you go. Which side effect? So what bodily fluid is this? Yeah. Yeah, ectocooler, Kool-Aid. What can give you blue urine? Methylene blue can give you blue urine. What can give you orange urine? Rifampin, azo, phenazopyridine can do that. Those are the big ones. How about tea-colored urine? Rhabdo, yep. You don't want to see that. Okay, the correct answer is propofol. So you see this more in ICU patients who are intubated and are on this for kind of like long-term sedation. You'll sometimes see this kind of greenish coloration of the urine happen there. What are the biggest side effects to worry about from etomidate? Think about things like adrenal suppression, right? It's a big deal when you're like intubating your patients with like sepsis and whatnot, because that can. Yeah, myoclonus and trismus you can see, so that can make it more difficult to intubate. Midazolam, you don't really see any issues with that one necessarily. Ketamine, what kind of issues can you run into with ketamine? Bad dreams, that dysphoric reaction, yeah, so you can certainly see that. Actually, kind of funny. I was teaching. I'm teaching a new class over at UF, and I was talking about I do a get to know you, and I say, what's your favorite drug? And so I said mine's ketamine, because I give little kids ketamine. Not recreationally. It's only in the professional setting. But yeah, so in one of the students actually had brought her kid there to Nemours at some point, and received some ketamine. So it was very cute when her kid woke up, still having like her fingernail like reattached, and was just like, "Thank you so much for taking care of me." It's a very sweet drug. Like your kids usually come out of it very, very nice, but adult patients not so much. They come out and swing in, and it's a derivative of PCP, so it's understandable they get a little freaked out. Anywho, all right. A patient with an allergy to lidocaine could safely receive which of these anesthetics? Just remember the two big classes of anesthetics? Local anesthetics? Apparently not. That's probably the right answer. Expectancy a pretty widespread here. Oh, why is time up? Oh, did I forget to... I might have goofed up the time on that one. I apologize. I looked and I thought I had 60 seconds on everything, but I goofed that one up. Okay. Well, anyway, we'll talk about why that's the right answer. Why is that the right answer? So remember, with your local anesthetics, there's ester anesthetics and there's amides. You guys remember how you can tell if it's an amide or not? If there's an I before the cane, right? So if you receive lidocaine, it's an amide anesthetic. If there's no I before it, it's an ester anesthetic. So again, there's very low cross-reactivity between the two groups. So if you have a problem with the amides, you can receive esters pretty much safely until proven otherwise, and vice versa. So with here, procaine does not have an I before the cane, but bupivacaine, prilocaine, mepivacaine, those are all amides as well. So there's a higher chance for cross-reactivity. Does that make sense? Okay.
Oh, anywhere in the...
Yeah, anywhere before the cane. Not right before the cane. Yeah, anywhere before the cane in the name. Yeah, so that's a handy trick for remembering the difference. There's two I's, it does not cancel out. Just any I's before the canes. So like benzocaine would be... That would also be an ester. Yeah. That's also my grandma's name. I'm just kidding. That's not my name. Okay. Which of the following areas can you safely inject lidocaine?
Definitely.
That's a horrible question.
I don't know. We'll find out. You guys are going to be practitioners. They're not going to tell you if you're right or wrong when you treat a patient. You got to figure this stuff out. Where can I inject lidocaine safely?
What?
They're all correct. So what was I trying to get at with that question? The epi is the important part, right? It's not the lidocaine that matters where you inject that. You can go anywhere, right? The issue is we don't want the epinephrine because that causes vasoconstriction. And what happens if we cause vasoconstriction in these areas? Decreased blood flow, decreased oxygen delivery, run the risk for having that necrosis happen there. So we don't want to do that. So any of these places are going to be fine. Certainly the fingers, we do lidocaine in the fingers all the time. And again, it's just like kind of the tips. It's really the big thing you want to be more concerned with. Good. Again, I'm not going to give any trick questions on the test. This is just for study purposes. And my own personal amusement, absolutely. Okay, a patient taking zolpidem for sleep is at risk for all of the following except... Don't Google zolpidem. Google your mind about your memories. I do appreciate you brought some Mountain Dew for this review. Seems appropriate.
Same flavor, none of the sugar.
Yeah. The diet do.
I get a stipend from.
That's good. It'll be on the internet too, so we'll get some marketing revenue from that. All right, what will they not be at risk for from taking Zolpidem for sleep? What type of drug is this?
Sleep aid.
Sleep aid. How do we think it works? So you guys remember how these drugs work? The Z drugs. How do they work? They work GABA. Yeah. So they work very similar to the benzodiazepines. They're kind of working on the benzodiazepine receptor sites. We call these the Z drugs, but they're still kind of like benzo-like. They're a little bit more specific in the subtypes that they affect. But yeah, so you'd be at the same risk that you would see with your benzodiazepines, right? So you'd be at risk for daytime drowsiness. You know, they formulate a lot of these drugs so that way some of them are shorter acting, so they can help with more sleep initiation, but certainly daytime drowsiness is a side effect you can see with these drugs. Tolerance. What do I mean by tolerance? Yeah, as your body gets used to having that dose around, you may need more drug in order to help keep you going to sleep, right? Because you're going to get used to having that GABA effect around. And then physical dependence. Right. Right, now I need this drug in order to sleep because otherwise I'm just going to be wide awake all night, right? So physical dependence is certainly a risk because, again, these drugs are what controlled schedule? Actually 4. So the benzos, all these drugs are going to be in group 4, right? And so remember, there are some sleep agents that are not controlled substances, right? So you can take a look at those. Things like melatonin, you know, not going to be a controlled substance, but you can still see some of that kind of physical, not dependence on it, but certainly the tolerance that can happen. Sometimes some rebound, you know, wakefulness that you'll see where they may need to still go to sleep. But they are not at risk for seizures, right? Because we're actually enhancing GABA effects, so that would obviously be protective against seizures in any case, right? All right. Continuing on. See, Trap Queen starting to make an appearance? Okay. A patient with a history of malignant hyperthermia can safely receive which paralytic? So either they have a family history of it or they've had it previously. Which paralytic can they receive? What did I say? What do we think? And the correct answer is, we had 3 right answers. There's lots of paralytics you can receive with a history of malignant hyperthermia.
Exams have 3 answers correct.
What'd you say?
Have 3 answers correct on the exam.
Wouldn't that be nice? No, we're not going to do that. They get mad if I start off multiple things. But right, so why can't they receive succinylcholine? Right, so they had those, and again, why do people get malignant hyperthermia? What's the mutation they have? Yeah, they have excess release of calcium from that sarcoplasmic reticulum is due to that ranitidine receptor that they have that's mutated. So again, if they have a family history of it, if they've had a previous history of it themselves, you definitely want to avoid succinylcholine. What else do you want to avoid? Yeah, a lot of those inhaled anesthetics you want to avoid as well because those can also cause malignant hyperthermia. So again, that's why you always ask, have you had bad reactions to anesthesia? Because they might not have known which specific drug it was. But any of the other non-depolarizing neuromuscular blockers like Rocuronium, Vecuronium, Cisatracurium, those are all okay to give. And how do those work? So non-depolarizing, so what do they do? Remember, they sit on those nicotinic receptors on the neuromuscular end plate, and they don't allow for any activation by acetylcholine, right? On the other hand, succinylcholine, how does that drug work? Activates those receptors, those nicotinic receptors, right? So that's why you see the initial fasciculations, and they're called depolarizing neuromuscular blockers because it goes and activates the receptor, and eventually tires it out, and then you get this flaccid paralysis, right? So important distinction to delineate, which of your paralytics you're dealing with, and which is why we use a lot of patients just go straight with Rocuronium, or a lot of providers do, because it's a lot safer to give in a lot of cases. All right.
What's the advantage of succinylcholine? It's faster.
It's fast and it has a fast offset as well. So if you needed to say like do a neuro exam on your patient after you intubate or something, like you're faster to get back to their baseline. Roc or Vec, like you're expecting 20-30 minutes they'll stick around. Usually with succinylcholine 10-15 minutes they should be relatively back to baseline. You guys remember how we test for level of paralysis? We do that train of 4 thing where you actually put it on that ulnar nerve and check for the thumb twitches. Right, so fewer twitches means more paralyzed. So no twitches means you're completely paralyzed. Usually you like to stay in that kind of 2 to 3 kind of range. Okay. So moving on. Which patient can safely receive succinylcholine? There's a couple of cases. It's important to remember your contraindications for succinylcholine. So spinal cord injury that occurred 3 hours ago, hyperkalemia and renal failure, severe burn that occurred last week, or crush injury that occurred 3 days ago. Who could safely receive succinylcholine? So timing is really important for these contraindications. It's important to remember the time frame for some of these injuries and what happens. Okay. So why is this the correct answer? Huh? Because that's a check on it? No. It's a correct answer because it takes time in these conditions where you have like crush injuries, or you have spinal cord injuries, or you have significant burns. It takes time for those nicotinic receptors to start to upregulate, and so 3 hours is not enough time. It takes 2 to 3 days or so for it to start to really kick in. So the patient who had a crush injury 3 days ago certainly not be a candidate. The severe burn that happened last week, I probably would still avoid it for the most part. And then why the hyperkalemia? Why is that a contraindication? Yeah, when you depolarize all those nerves, all those muscles, you're going to cause a lot of release of potassium. So at least a 0.5 milliequivalent per liter kind of increase in potassium levels. If they're already sitting at like 6 or 6.5 and you bump them even further, risk for arrhythmias, right? So that's why we avoid those in patients with already existing hyperkalemia. Okay, again, that 3 hours is kind of the key point there. All right, 12 players with a 4-answer streak. I should have made this harder. Just kidding. All right, so a patient in VFib, cardiac arrest, has not responded to defibrillation. Which med can now be used? So they didn't respond to any electricity. What can we give them now? They're in VFib arrest. Again, this is according to the ACLS guidelines. What do we think? Just answer anything, last 2 people. You're fine. All right, so why is amiodarone the right answer? Also because it's a check on it, but if you go down to the ACLS guidelines, right, what are we normally giving for people in cardiac arrest, med-wise? Epi, right? All you're giving is epi, basically. We used to give sometimes atropine, don't really do that anymore. Sometimes we used to substitute a dose of vasopressin in for a dose of epi, don't really do that anymore. It's not really shown to be beneficial. What would I use digoxin for? Yeah, AFib would be the big place. And again, not going to be a patient in VFib arrest. Why not adenosine? Yep, that's right, SVT, right? So again, this would not be a good drug for that patient. Lidocaine probably could have been a correct answer years ago, but again, amiodarone has really kind of moved to be your kind of go-to ventricular arrhythmia kind of med in the rest kind of situations. If amiodarone was not available, you could try lidocaine, but again, it's just not our go-to drug. So amiodarone would be the correct answer in that situation. Obviously, if they're in VFib arrest, you want to try shocking them first, but if that's not working, then you can try some chemical cardioversion there. Okay. All right. What is the ratio of elemental calcium in calcium chloride to calcium gluconate? It's important to remember, since if you get your doses wrong, you can end up giving someone way too much elemental calcium or way too little, depending on the situation. So 1:3 ratio, 1:5, 1:10, or 1:1 ratio. What's really bad is I tried to make one where there's like no right answers and it wouldn't let me. So I was like, oh, that would have been really mean. So you can at least be sure there's at least one correct answer for every question.
You could do a none of the above.
Yeah. And that's kind of obvious. If you put none of the above, like it's always none of the above. In general, that's why we don't ever have those questions here on your test. You'll never find out all the above or none of the above. You shouldn't, at least.
I thought you can't because it shuffles on.
No, I mean, you guys can figure out, like, all the above probably refers to all of, not specifically, all the above is B and then A is that, yeah, I don't think I get that granular. Okay. Okay, so this is a 1:3 ratio, right? So looking at the actual amount of elemental calcium in a gram of calcium chloride, because again, they both come in a 1 gram vial, they both come in as a 10% solution. It's 1:3, so you need 3 vials of calcium gluconate to equal the elemental calcium in 1 gram of calcium chloride, right? Just because like gluconate molecule is larger there. Why would we give calcium gluconate versus chloride? It's a lot easier on the veins. Calcium chloride is very, very irritating to the veins. You see a lot of thrombophlebitis. So the issue you run into is if a patient is alive and they're still circulating, we like to give calcium gluconate, right? Because that way we can infuse it at a slower rate. We can, not really worry about irritating the veins. We always like central lines whenever possible for giving calcium, just because it is so irritating. But if the patient's coding, then we'll push calcium chloride. So I don't know if I mentioned it last 2 weeks ago. I actually got to participate in a code that happened at Nemours. Unfortunately, the patient did not make it, but it kind of illustrated a lot of the good points of when you're running any code, but pediatric code specifically. So did I mention this to you guys at all? Okay, so basically, I believe it was a 2-year-old child. It had some history of genetic sort of anomalies, which I didn't get the full history on. Basically, I'm down in the ED, get the call, hey, can you get a pharmacist up here? So okay, run up and call the code blue and all that. So unfortunately, a patient had been kind of going down the wrong path anyway. They're actually discussing whether or not to do ECMO on that patient or not, but in coding eventually. And so good illustration of things like, okay, well, the patient's coding, they need calcium. So we end up giving calcium chloride instead of gluconate. I don't know if the patient actually had a central line or not, but it's one of those things where they're coding, just give them, as much calcium as you can give them, in small volumes. So we like to do the calcium chloride because, again, they're not perfusing very well. The only perfusion they have is what we're supplying for them, right? So that was one thing. I had another pharmacist who was there, ended up showing up there, and you guys remember I was talking about those Bristol-Jets, right? The kind of pre-done syringes you can attach to one another. You have the tube basically has the needle end on it, and then you have the glass vial that has the drug in it. Sure enough, they tried to open up the box from the wrong side, and that's actually a really important thing. Where if you there's only one right way to open those boxes. And it says, little tab says open on it to where you pull them up. If you do it on the opposite end, the drug doesn't come out because the cardboard's situated in a way that it doesn't fall out unnecessarily. So of course they try to open the box on the wrong end, trying to get the drug out. Patients code and they're freaking out like, oh my gosh, what do I do? So it's like, okay, slow down, open it from the other end. Okay, now we can get our drug out and do all that. So that was one thing we ran into, just as a logistic kind of problem. The other thing is with pediatric codes, you have to draw out doses out of those vials, because usually for like adult codes, you can give a whole amp of D50, or you can give a whole amp of bicarb or whatever, and that's the adult dose, right? But for kids, you have to individualize it for that patient's weight. So she's roughly like 12 kilograms or something. So we're having to get relatively small doses for these drugs. And so how do you get those doses out? Well, there's a couple ways you can do it. And we end up using a 3-way stopcock. Okay, so you attach a stopcock to it, you have your drug on one end, you have your syringe on the other end, and you just draw it out, right? Well, one person was trying to hook that up, and they couldn't figure out how to get the actual drug out of there, and so I said, well, you got to turn the stopcock this way, and then all of a sudden now the drug will come out. So again, little logistic things that are not really a big deal until you're like in the middle of kind of like a hectic situation. Patients, dead for all intents and purposes, and you're trying to get drug out. So it can be one of those kind of things you run into with, especially if you have a small team or an unpracticed team, you can hit those issues more commonly. But anywho, but yeah, for that patient, we ended up doing just a ton of epi. Every 3 to 5 minutes or so, we were giving epi, and then based on eye stats and stuff that we were getting back, looking at blood gases, we were giving. She ended up having hyperkalemia, so we ended up giving. Do you guys remember what drugs we give for hyperkalemia? Bicarbonate, yep. So we were giving bicarb. She was acidotic anyway because she was not perfusing, getting acidotic, so we gave bicarb.
Insulin.
Yeah, so we gave insulin and dextrose as well. So we had to run over to the pharmacy, grab regular insulin, and we ended up giving a dose IV with the dextrose in order to help drive that stuff intracellularly. I think her potassium was up like 7.5 or something like that. Hard to say if it was any hemolysis or anything, but potassium was high regardless, so we were trying to treat that. Also, we gave the calcium to help with that as well, because that helps to stabilize that myocardium, right? So those are the big kind of main things we were trying to do for that patient, which unfortunately did not go well. Okay. Now I've doubted everyone's mood. A patient who's hypotensive and bradycardic, which pressor do you think would be best suited for this patient? Back, do we use vasopressin? Should we use dobutamine, milrinone, or epinephrine? What should I use? They're bradycardic and hypotensive. Nurse calls you up, says, patient's not looking very good. What do you want? Say, hold on, I'm going to check with my attending. Say, no, I got the right answer.
More choices.
You give me 4. What do you have? What's on the menu tonight in the ICU? Could there be multiple right answers? I don't know. You guys can't trust anything that I say anymore. I don't even actually work at Nemours anymore. I'm just kidding. I do. Every Friday night. So epinephrine would be the correct answer in this case. So again, go back to your mechanisms and look at how these drugs are affecting the cardiovascular system, and this will make more sense, right? So they're bradycardic and hypotensive, so we want something that's going to help with the squeeze in the heart. So we want something that's better, a good ionotrope. We want something that's going to help to increase the squeeze on the vasculature, right? So we need something to act on both alpha receptors, right, which is going to help with our vasoconstriction, and something on our beta receptors, right? Particularly beta 1 is a big thing we want to hit. So vasopressin, what does that do? Basically antidiuretic hormone, right? So it's helping to keep water, hold on to water and salt, trying to help keep the intravascular space filled. That's not really going to, it can help with our blood pressure, but it's not a go-to vasopressor to help fix this patient's issues, right? It's kind of an add-on drug that you can help once you have other pressors on board already. So that's not the right answer. How about dobutamine? What is that? So that's primarily a beta 1 agonist. So since it's only acting on the heart, it's not going to help with our hypotension so much. So that would not be the correct answer either. How about milrinone? Do you guys remember what type of drug that is? It's a phosphodiesterase inhibitor, but it's not working on PDE 5. It's working on PDE 3, which is more specific to the vasculature. So what would that cause for us? Cause vasodilation, but what does it do to the heart? It's actually an ionotrope, so it actually helps to increase the squeeze on the heart, because sometimes we'll give our decompensated CHF patients, right, who are probably hypertensive anyway, they have poor cardiac output, so we can give this to give them a little bit better squeeze and maybe decrease some of that peripheral vascular resistance, right? So that is not the correct answer in this case, because it would worsen their hypotension potentially, okay? So epinephrine would be the good answer because it works in a balanced way on both alpha and beta receptors, right?
When would we use dopamine?
Dopamine could also be used as well. You have to remember, though, that the dosing ranges and how that affects the receptors differently, right? So you guys remember at low dose dopamine, say like 1 to 5 mics per kilo per minute, what does that affect primarily? Dopamine affects the dopamine receptors, right? So it's primarily going to be more relegated to like kidney flow and things like that. So that's not really what we want. At the 5 to 10 range, you're going to be primarily getting some more beta activity, so that would be better for increasing cardiac output. Okay, when you get the higher doses, say 10 to 15 range, that's when you're going to get more effects on the heart and on the vasculature, getting some squeeze. So I would probably use high dose dopamine in this case as well. That would be another good option. Norepi is going to be primarily on the vasculature. It's going to be a little bit more balanced on the alpha side. That one could be okay as well, but for bradycardic hypotensive patients, I like epinephrine. It's kind of a good go-to. Okay. Phenylephrine, how does that work? Yeah, so phenylephrine's alpha only, so that would not be a good one for this patient because it wouldn't help with their cardiac output at all. Okay, it would just help with the vasoconstriction. All right. Moving on. 3 more questions. Which of the following is required for a prescription of HCTZ or Huctaz? For the prescription to be valid, you can have all these things on there. But what is required for it to be a valid prescription? And remember, it's a prescription, not a prescription. Had some issues where we keep blank prescription pads in our Pyxis machines in case like docs ever need to like write something that won't come out of our EMR. And I had a nurse who was like, I can't. There's no prescription pads in here. There's no paper in here. I'm not looking at the server and I'm like, yeah, there's obviously stuff there. I was like, and you have to type in the letters that you're searching for to find the thing. And I was like, how'd you type it in? And she was like, P-E-R. I was like, okay, there you go. P-R-E. I see it now. Thank you so much. Yeah. Okay. All right. Okay. So do we have to have indication on the prescription? No, it's nice to have, but you don't have to have an indication on there. It helps to prevent phone calls, certainly, if it's for something, especially if you're writing that's not super common. Do you have to have a DEA number? Yeah, those are for controlled substances only. And again, this is another way we can look up providers. So again, it's nice to have. Most of your scripts will probably already have it on there, right? Because for a lot of these, they're going to be kind of pre-printed kind of scripts for you, and they'll have that information. Handwritten signature. Only really need those for C2s, right? So for anything else, you can, I can verbally call in a prescription for HCTZ. That's not going to be a problem. There's no signature involved in that case, okay? So you don't have to have a handwritten signature, only C2s. But quantity dispense, you absolutely have to have, okay? So you need to know how much you're supposed to be dispensing to the patient. Otherwise, it's not really a valid script at that point, okay? All right. Which of the following is required for a prescription of oxycodone acetaminophen, so our Percocets, to make it a valid prescription? The shape's distracting you. Should put more pictures. What is required?
You should bring Jeopardy music.
I'll just play it right here. Yeah. Okay, so do I need the patient's driver's license number on the prescription? No, they don't have a driver's license. We typically will on the pharmacy end when they come to pick up stuff, we will use their driver's license to we actually scan it in to our computer system, and that way it actually can track things like eForce, right? So that way we know we have all the patient's information automatically gets filled in and all that stuff when we send that information out. So we will use that when we're trying to identify the patient. Prescriber date of birth. No, you probably should want the patient date of birth on there, but again, not necessarily required. Expiration date. Well, remember, C2s, like, they're going to fall shorter. Again, like, it's one of those things where they're going to get filled. Usually, like, probably, I guess technically, it'll probably fall under the 6-month rule like the C3 through 5s. But again, most non-controlled prescriptions are going to be good for that full year. These things, again, you're writing only, you have to write individual scripts. The max you can do is a 90-day supply anyway, right? So, and again, if a patient is coming to fill something like a C2 and it's like 6 months past when it was written, like I'm not going to fill that, right? Like why didn't they come forward with that? You know, it's just a little kind of sketchy at that point. But absolutely have to have it on counterfeit proof paper, so that way you can't photocopy it and take it to every pharmacy in town, right? Okay. The last question: which of the following is an error-prone abbreviation? Which of these could you misread on a prescription and fill it with something else? Or get the numbers wrong? People like to wait down to the wire. They're saying, Okay, so all of them are error-prone abbreviations. Don't use abbreviations whenever possible. It will make it more likely to see issues there. Right, okay, so what does QD most often get mistaken for? Like QID potentially, yeah, sometimes maybe. That's probably the most common one you see. So what do you do instead? Daily, yep, that's a big one. How about IU? That can be misread as 10. So you want to watch out for that. And again, when you're dealing with like insulin and things like that, should you put it? Yeah, units. You can write international units, but units is usually sufficient enough to make that pretty clear. How about MSO4? What is that? It's actually morphine sulfate. So that would get mixed up with magnesium sulfate. So if you saw MgSO4, that would oftentimes get mixed up there. And then QHS, I think it can be misread for. VHS, yeah, absolutely. Most of your patients will be too young to not even. No, I'm just kidding. Yeah, I forget which one they actually say that one gets confused for, but obviously you can just write for sleep or take at night, you know. That again would prevent those kind of errors from occurring there. So again, be very careful with abbreviations. Most of them are going to be error prone to some degree. All right, who's our winner? We have VH. Who's VH? Who's you? Oh, yay, good job. Congratulations. You get a fake gold medal. And then who's Trap Queen?
I'd be in the kitchen cooking pies.
Yeah? There you go. And then Fitzhugh Curtis. Mr. Curtis? Oh, there you go. All right. Fantastic. So good job, guys. You can come to my office and I will pat you on the back. Otherwise, that's all you get from me. Okay. So any questions on test material, anything we covered? You have lingering questions about that I can answer for you? No? Okay. So again, this will be your last class from me. So if you have any questions, you can feel free to email me up through to the test. Otherwise, it'll be on Monday, right? I think our test is on Monday. Okay. So if you have any questions over the weekend, hit me up. Otherwise, I will see you guys around. I'm always just an email away. If you ever have any questions or anything that comes up, feel free to reach out to me. And then I guess we'll finish up our research methodologies, and then you guys will be done with me. You can take this yoke off of your necks and say, no more. Okay, I will see you guys later.